Hey there, health enthusiasts. Welcome back. Today, we're delving into infantile spasms. Before we start, don't forget to share the video with your friends and family, and subscribe for more content. Now, let's get started. Most cases occur younger than 12 months, with peak age of onset is 3 to 7 months. Infantile spasm typically occur in the context of West syndrome, characterized by the triad of IS, hypsarrhythmia on EEG, and developmental arrest/regression. Not all children with infantile spasms have all the features of West syndrome. Infantile spasm is associated with developmental delay in over 80% of infants and high rates of ongoing epilepsy. Prompt diagnosis and treatment are critical to minimize the developmental impacts. The frequent onset of infantile spasms in infancy suggests that an immature central nervous system may be important in the syndrome's pathogenesis. The brain-adrenal axis also may be involved. The theory states that the effect of different stressors leads to excessive secretion of corticotropin-releasing hormone, causing spasms. Common causes include tuberous sclerosis complex, trisomy 21, focal structural abnormality, perinatal hypoxic ischemic encephalopathy. Infantile spasms can be classified according to their suspected etiology as symptomatic. This means they have an identifiable factor. Most cases have symptomatic epilepsy. Anything that causes brain damage can be classified here. They further can be subdivided into prenatal disorders, which include tuberous sclerosis, trisomy 21 hypoxic ischemic encephalopathy, congenital infections, trauma, hydrocephalus. Perinatal disorders include hypoxic ischemic encephalopathy, meningitis, encephalitis, trauma, intracranial hemorrhages. Postnatal disorders include mitochondrial encephalopathies, meningitis, encephalitis, trauma, pyridoxine dependency, metabolism errors. Then we have cryptogenic, where no cause is identified but a cause is suspected and the epilepsy is presumed to be symptomatic. Finally, idiopathic. There are studies about the role of genetic defects in the etiology of infantile spasms. The long-term overall prognosis for patients with infantile spasm is poor and is related directly to the condition's etiology. Symptomatic infantile spasms have a poorer prognosis and higher risk for the development of autism spectrum disorders. Favorable prognostic factors also include the following: cryptogenic or idiopathic etiology, age of onset of over 4 months, absence of atypical spasms and partial seizures, absence of asymmetrical EEG abnormalities, short time from onset to treatment. Early, sustained response to treatment. The child will present with sudden, rapid, tonic contraction of trunk and limb lasting 5 to 10 seconds that gradually relaxes over 0.5 to 2 seconds. The intensity of spasms varies from a subtle head nodding to a powerful contraction of the body. They occur in clusters, several dozen spasms, each separated by 5 to 30 seconds. Spasms frequently occur just before sleep or upon awakening. Spasms can be flexor, extensor, or a mixture of flexion and extension. Flexor spasms consist of brief contractions of the flexors of the neck, trunks, and limbs, resulting in a brief jerk. They may resemble a self-hugging motion and often are associated with a cry. The patient then relaxes, and the jerk repeats. These attacks occur in clusters throughout the day and last anywhere from less than 1 minute to 10 to 15 minutes or longer in some patients. Extensor spasms consist of contractions of the extensors, with sudden extension of the neck and trunk and with extension and abduction of the limbs. Extensor spasms and asymmetrical or unilateral spasms often are associated with symptomatic cases. Mixed spasms are the most common type. May be asymmetric. During history or examination, there may be features that provide clues to the underlying cause. A pre-existing condition known to be associated with infantile spasm, for example, tuberous sclerosis, trisomy 21. Family history of seizure disorder or developmental delay for a genetic basis. Early handedness can suggest a focal structural abnormality. Ophthalmic examination may reveal chorioretinitis from congenital infections, chorioretinal lacunar defects in patients with Aicardi syndrome, or retinal tubers in patients with tuberous sclerosis, dysmorphic features or congenital anomalies for chromosomal abnormalities. Wood lamp examination of skin for hypopigmented macules of tuberous sclerosis. Pre-existing developmental delay. Neonatal or early infantile seizures. Head circumference growth. The differential diagnosis that need to be considered include non-epileptic episodes such as shuddering and benign myoclonus of infancy. Benign myoclonic epilepsy of infancy. Other infantile epilepsies. Evaluating children with infantile spasms for possible tuberous sclerosis is critical, as this is the single most common disorder. Tuberous sclerosis is an autosomal dominant inherited disease with variable manifestations, including cardiac tumors, kidney tumors, cutaneous malformations such as ash-leaf hypopigmented lesions, and seizures. Need to do all basic lab studies. Complete blood count, liver and renal profile, metabolic profile, and cultures if the infection is suspected. CSF analysis. Urgent awake and sleep EEG, and interictal EEG, can show hypsarrhythmia. Chaotic, high to extremely high voltage, polymorphic delta, and theta rhythms with superimposed multifocal spikes and wave discharges. Imaging studies should be obtained before starting ACTH or steroid therapy. Prompt MRI brain. Other investigations for underlying etiology, if unknown, including chromosomal microarray, urine metabolic screen, and consideration of other genetic testing. Medications such as ACTH, oral corticosteroids, vigabatrin, and conventional antiepileptic drugs have all been used. In some patients, resection of a localized region can lead to freedom from seizures. Studies have shown ketogenic diet can be considered for infantile spasms, according to RCH Guidelines for infantile spasm management. High-dose prednisolone is the first-line treatment, except for tuberous sclerosis and treatable metabolic conditions. Prednisolone 10 mg QID for 1 week then. If spasms cease during this week, continue 10 mg QID for 1 more week, then wean off 10 mg every 5 days, for example, TDS to BD to once daily then cease, for a total of 4 weeks of treatment. If spasms continue after week 1 of treatment, the prednisolone dose should be increased to 20 mg TDS for 1 week, then wean to 10 mg QID, then BD to once daily, and then cease. Vigabatrin is the second-line treatment after 2 weeks of inadequate response to corticosteroids, and should be added to the weaning prednisolone regimen. Vigabatrin is recommended as first-line treatment for tuberous sclerosis. First-line treatment with a combination of prednisolone and vigabatrin has a higher rate of spasm cessation but showed no improvement in developmental outcome at age 18 months over prednisolone alone. Also, vigabatrin is associated with potential ocular and neurologic side effects, so can be considered on a case-by-case basis. Precautions and monitoring while taking prednisolone. High doses can increase infections risk. Any child with infantile spasm on prednisolone who presents febrile or unwell should be admitted and managed as per the sepsis guideline. Consider infectious disease consultation. If there is vomiting or significant diarrhea, administer 4/IM hydrocortisone. Prophylactic trimethoprim sulfamethoxazole for infection prevention. Monitor BP, blood glucose, and weight twice weekly. Vaccines should be delayed until 1 month after ceasing prednisolone. When discharging the child, RCH Guidelines states that the child needs a follow-up arranged with a neurologist or pediatrician with input from a neurologist, and a follow-up EEG booked after 2 weeks. Admission for infantile spasm diagnosis and initial management is usually brief, and discharge is not dependent on spasm cessation. The steroid alert card should be given to parents before hospital discharge regarding treatment in the event of becoming unwell or febrile. We conclude today's discussion on infantile spasms. If you found this video helpful, please consider sharing it with others who may benefit from the knowledge. Thank you for joining us today, and we look forward to bringing you more informative content in the future. Until next time, take care and stay well.